Good afternoon. I am Margaret Crawford from UCare, and I'm happy you've joined us for our Meeting the Challenges of Diabetes updates with the pharmacists. This training is the second in a series to help care coordinators, case managers, and others better understand diabetes, its impact on persons living with diabetes, and how to best support members to best manage their condition. The following 6 health plans work together to improve quality of care for our Medicaid members. We have Blue Cross, Health Partners, Hennepin Health, Medica, South Country Health Alliance, and UCare. We're very lucky to have Kaylin Maddie and Grant Shaft, PharmD staff from UCare, share their time and knowledge with us. I will let you guys take over and begin your presentation. Thanks.
Sounds good. Well, hello everybody. We are here today to talk to you all about diabetes care and medication therapy management, or MTM. My name is Kaylin Maddie, and I'm a clinical pharmacist at UCare, where I provide MTM services. And prior to my time at UCare, I spent a year doing a pharmacy residency. Mainly, I did medication therapy management in the clinic settings at Park Nicollet, but I also spent some time at the Health Partners plan.
My name is Grant Shaft. I am another clinical pharmacist at UCare that works in MTM. I have had some experience in a clinic during my residency, similar to Kaylin. I then spent some time at Walgreens where I set up an MTM program and ran it for about 3 years. Had some time at Prime Therapeutics, and now I'm here at UCare and loving the managed care side. So for today, we have some pretty basic objectives, but we really want to provide you with some notable changes that have happened in diabetes medications, as well as some of the treatment guidelines. We'd also like to give you a preview into the life of a medication therapy pharmacist and how a pharmacist can help assist patients in diabetes. So for our agenda today, we plan on going through any updates through the ADA, talk about some drug updates, talk about how diabetes and over-the-counters can mix, talk about continuous glucose monitors and some changes that have happened within Medicare. Kaylin's going to talk some about statin use in diabetes and those important measures. And then we're going to finish off with some medication therapy management and just general what it is. So I'll turn it over to Kaylin to give us some updates.
All right, so I'm going to start us off by talking about the American Diabetes Association, or ADA, guideline updates. And the ADA guidelines are called the ADA Standards of Medical Care in Diabetes. The most recent version is 2021, and this was updated in December of 2020. And the ADA guidelines, really, it's a very long document that tells us all sorts of interesting information about anything you might need to know about managing diabetes. And we, since we're pharmacists, we're going to focus on medication updates, but we'll talk about a few other things as well. Starting off with goals. So A1C is the big test to measure diabetes control. If somebody is at goal, it's recommended to test the A1C every 6 months. And if somebody's not at goal or has had any recent medicine dose changes, it's recommended to test every 3 months. For blood sugar readings, what are we expecting for an A1C of less than 7%, or what are the goals? For a fasting blood sugar, the goals are between 80 and 130. And then for postprandial, which is 1 to 2 hours after starting a meal, the goal is less than 180. This is a very helpful figure from the guidelines. Really just, it helps to point out that an A1C goal of less than 7% is definitely not appropriate for every patient. So it just highlights that A1C goals should be individualized, and it points out different factors that you can look at to help decide what an A1C goal should be. But in summary, what I like to say about it is that a less stringent A1C goal, maybe one of less than 8%, might be appropriate for patients that, say, have a limited life expectancy, or where the harms of treatment might be greater than the benefits. So I think about this a lot in patients who are older or maybe sicker with more comorbidities. Here is a table from the guidelines that's very helpful. This table can be used to help estimate A1Cs based on blood glucose readings. So this can be very helpful for individuals to use in between A1C appointments. And the way that it works is that it just shows you what an estimated, what if you're looking at the A1C, what some of the blood sugars might be if you're within that goal range. So looking at the averages, and this can be very motivating for individuals, just so they know what they're looking at in their blood sugar readings and what they might be able to expect their A1C to come back as. Next, looking at hypoglycemia. So there are 3 different classifications of hypoglycemia from the guidelines. The first is level 1. So this is looking at a blood sugar reading less than 70. The next is level 2, a blood sugar reading less than 54. And then the third, level 3, is classified as a severe event that's characterized by altered mental and/or physical status that requires treatment for hypoglycemia. And here, what I just want to point out is that glucagon is recommended for those at risk of level 2 or level 3 hypoglycemia. And then just a reminder that there's an injection and a nasal spray form available for glucagon. All right, now moving on to the medicines, we're going to focus mainly on type 2 diabetes here. I know that this chart is very hard to see. It's very small, and that's just fine. In the coming slides, we're going to zoom into the different sections. But just pointing out here that starting at the top, first line treatment is always metformin and comprehensive lifestyle. And then from there, you kind of move into 2 buckets. So on the left, we have those who have established high risk factors. And then on the right, we have those who do not have the additional risk factors. And you may have seen this before, you may not have, but what's newer to this is that they added 2 more buckets. So here they added heart failure and chronic kidney disease. But now we are going to zoom further in here. So focusing on those different high risk groups that were on the left. The first group is the group in blue. This is the ASCVD group, which is looking at cardiovascular disease or those that are high risk for cardiovascular disease. Next in red is a group for heart failure. And this is focusing on reduced ejection heart failure. So that would be those who have an ejection fraction that is less than 45%. And then the third group is the CKD group. And this is split into 2 buckets. One is just general chronic kidney disease. And then the other is diabetic kidney disease with albuminuria or protein in the urine. Next, we'll go into each of these buckets and what specific types of medicines are recommended for the different buckets. And I know that you guys may not be the ones that are prescribing these medicines, but it still is very, very helpful to know what the additional benefits are for, just because it's nice to talk with people about what the drugs are doing besides just helping with their blood sugars. It can be very motivating for people. So starting with this first group, the cardiovascular group, a GLP-1 or an SGLT2 inhibitor medicine is recommended, and they do recommend picking one with proven cardiovascular benefits, and we will go more into those in a minute here. Next, looking at the heart failure group, in this group, an SGLT2 inhibitor is recommended, and again, one that has proven benefit for this indication. And the next group, the chronic kidney disease group, as I mentioned before, they split this up into 2 groups. So for the diabetic kidney disease group with the protein in the urine, an SGLT2 inhibitor specifically is recommended, whereas for the chronic kidney disease group, they recommend either a GLP-1 inhibitor or an SGLT2 inhibitor. All right. And going back here, just try to zoom in on these little red boxes. So This is just highlighting when sulfonylurea medicines are recommended. And really, I just put this on here to point out that they aren't recommended very often, and they are recommended pretty low down on the list. Generally, they can be a good option if cost is a concern and if the other risk factors are low. But sulfonylureas do come with some risks like weight gain and low blood sugars. So they aren't regularly recommended. Next, just talking through a few pearls with medication adherence. And really here, I mean, before adding any additional medicines or changing doses, just always assess adherence and how often or how regularly people are taking their medicines. One of the big things to focus on here is open-ended questions. So just different ways of phrasing things, you'll get different responses from individuals. So I just threw in a few examples here, such as asking, how many tablets do you take per day? Instead of say, do you take 4 Met tablets every day? You'd be surprised how many people I've had, answer this question and find out they're just taking 1 tablet a day, not because they don't want to take 4, but because they don't understand. So this is an easier way to catch things. And then another is, how do things go with remembering to take your medicines each day, rather than just saying, do you take your medicines every day? Or another way that I sometimes like to phrase it is, in a given week or two, how many doses of your medicines do you miss? And then next, looking at combination pills for diabetes. So the cool thing about medicines is that there are some that it's one pill that contains multiple different drugs, which is very helpful and very convenient for people. So for diabetes, a lot of those exist. There's some combined with metformin, some combined with just other oral agents, and then there's even one that contains metformin plus 2 other oral agents. And I like to take advantage of these combination pills to, reduce pill burden. It can make things less confusing for people, and it also helps them to have to swallow less pills per day, which is always nice. Next, we're going to go through just a few quick drug updates that have happened as of recently. First, looking at the different indications for the different types of medicines. So we kind of briefly mentioned these before, but we are going to just go through each class. So this is looking at the SGLT2 inhibitors, which are Jardiance, Invokana, Farxiga, and Stiglatro. And here, what I'm going over is what else are they indicated for besides just helping with diabetes. So the X shows that they're FDA approved for these different areas. Now, I will say that some of these drugs do have benefits or evidence for benefits in other areas, but they just don't have an FDA approval, or at least they don't have it yet. So looking at these ones, we can see that 3 of them have the indication for cardiovascular benefits. 2 of them have a renal indication, and then 1 of them has a heart failure indication, which is Farxiga. So you can see that Farxiga has all of the indications here. Next, looking at a similar structure, but for the GLP-1 inhibitors, we have Byetta and Bydureon, Adlixin, Victoza, and then your once weekly injection options, the Trulicity and Ozempic, and then your oral option, which is newer, the Rybelsus. And here, as we can see, the biggest benefit for these ones that have the FDA approval is the cardiovascular risk reduction or prevention indication, but Ozempic does also have an indication for obesity as well. This is just pointing out that the DPP-4 inhibitors don't have any additional benefits, so they are used really just to help with the blood sugars, but they're minimal risk for side effects, so that can be nice in some individuals who can't tolerate other medicines. Next, moving on to Trulicity. So Trulicity is a medicine that's been around for a while, but as of recently, about a year ago now, they got FDA approval for some higher doses of Trulicity. So before there were only 2 doses approved, and now there's 4 doses approved. So there's 2 higher doses. And this is all based on the Award 11 study. And overall, what this study showed is that higher doses led to lower A1Cs and more weight loss, so more benefits with the higher doses. This is that same study, but looking at the side effects here with the different doses. And basically the side effects go up slightly when the dose increases, but it's not actually a significant increase. So it's tolerated pretty well even at the higher doses. Conclusions from this are that higher dose Trulicity is a great option if somebody is close to their A1C goal, but not quite there. And it is tolerated similarly to using the lower doses or to using Ozempic. And the big key takeaway here is that if somebody is on Trulicity and they're tolerating it well, but they need a little bit more help with their A1C, it's always a good idea to try to maximize the Trulicity dose first before adding another medicine, just because that can be burdensome for people to have to be on another medicine. And then last drug update is looking at Semglee. So Semglee is a new insulin, a long-acting insulin that was just approved about 3 weeks ago now. And this is the first insulin biosimilar, and it's interchangeable with Lantus. So what this means is that pharmacies can dispense this instead of Lantus without asking the provider if it's less expensive for the individual and if it's on their insurance formulary. And I will point out here that it is only interchangeable with Lantus, not the other types of long-acting insulins.
Thanks, Galen. All right, so next we're going to talk a little bit about diabetes and over-the-counter medications. I feel like this is a very interesting topic. I used to love jumping in the over-the-counter aisles as a pharmacist and showing people what medications would work well and be safe with all the medications that they're taking. I think a lot of times there's this idea that because they're over the counter, they're safe and they're okay. I can take whatever ones I want. Unfortunately, with diabetes, we need to be a little bit more picky with what we choose. So looking first at cough, cold, and allergies. First of all, clearly we need to make sure we're finding sugar-free formulations. When you think of syrups, cough drops, lozenges, I think the first thing I think about is all the sugar that can be in some of those. So trying to find options that don't have that in there will definitely be important. Additionally, many patients with diabetes have comorbid conditions such as hypertension. So we definitely want to avoid medications that can increase that blood pressure and go against some of their other medications. And so examples for that would be like Sudafed. So that's the pseudoephedrine, the stuff you get behind the counter, or phenylephrine, which you can find over the counter just in the aisles. And then any allergy pills that have like a D in it for the decongestant part. Those all can clamp down on the blood vessels, which increases blood pressure, which will not be very good for our patients. So if we do have to use something for the cough and cold, I usually recommend a very short course for it, perhaps 5 days, maybe 7 days if their blood pressure is pretty well controlled. And I like to use the short acting stuff. So if you were to get that behind the counter, it would be like the little red pills. A lot of times people refer to them as, so the 30 milligram dose of the Sudafed. Additionally, we look at things like antihistamines. These are a-okay. I think a lot of times we get concerned. We think of like Coricidin for colds and stuff like that. If we need to dry up our nasal passages and help with allergies, Allegra, Claritin, and Zyrtec are just fine. When we start to get into the Zyrtec D, the Claritin D, that's where we're going to have to consider blood pressure in that case. I know that prescription steroids are not a medication that or somebody gets over the counter. However, I think it's important to talk about. We just want to try to keep those courses as short as possible. And as you're counseling through a patient who might be on one of those for a respiratory infection, just understanding that those blood sugars might be elevated right now, but over time they should come back down related to that. Next is looking at pain. And so I think one of the biggest ones we look at is things like Advil, Aleve, or high doses of aspirin. And when I say high doses of aspirin, I mean more than like 325 milligrams in a day. And so we really want to avoid these long-term NSAIDs, non-steroidal anti-inflammatory drugs, if possible, in the long run. And there's a whole lot of reasons to think about that. Number one, they can be hard on the kidneys. We know that people with diabetes have an increased risk of kidney disease already. We want to try to protect those kidneys as long as possible. They can increase blood pressure over time. They clamp down on the kidneys and make it a little bit harder for us to lower our blood pressure that way. And in 2015, the FDA came out and really said there's no such thing as a safe NSAID taken at high doses over a long period of time, because unfortunately they can increase our risk of cardiac events. And so when I think of someone with diabetes, we already know that they're at a high risk for cardiovascular events, and you throw on NSAIDs, we're only elevating that risk exponentially. So we definitely need to look out for that. Additionally, a lot of patients are on aspirin in this case. Not only taking aspirin and NSAIDs at the same time can increase your risk of bleeding, but we also need to be worried because if a person takes aspirin and an NSAID at the same time, they actually cancel out the benefits of that aspirin if they take them at the same time. So what we try to do is counsel patients to take an aspirin first, wait at least 30 minutes before they take their NSAID, and that way they still get the antiplatelet action that helps protect the heart when someone is taking aspirin. Additionally, we talked about that blood pressure. Well, ACEs and ARBs, things like lisinopril or losartan, things that end in pril or sartan, those medications interact with NSAIDs over time and can actually lead to some slowdown of kidney function and potentially some damage there. And so in all cases with this, Tylenol is usually going to be safe unless a patient has liver disease. So that would be our safest option we could go to. And I know within the last 10 years or so, supplements have just blown up, I feel like, on the market. My wife is all about doTERRA, so I can definitely relate to some of that. We find that more and more patients are trying to find supplements that benefit their diabetes. Here's a small list of some of the ones that have some clinical trials behind them to show some benefit in diabetes. We can see that the majority of these, one of the first side effects I list is a hypoglycemia risk. Well, if they're lowering our blood sugars, they can absolutely cause a hypoglycemia risk. So it's not necessarily that it's going to dump them down to, the level 2 right away or anything like that. But it does need to mean that we need to be cautious if someone's on insulin or sulfonylureas, especially because we can help or we can bring that blood sugar down. These are all potentially good options. Now, we do need to think about how these interact with things. So for example, chromium, that can bind up to Synthroid or levothyroxine, which is a common disease state within diabetes as well. Garlic with interactions with 3A4. I know that doesn't mean a lot for people who aren't pharmacists, but for us, we think about statin medications are oftentimes metabolized through that pathway. So we might be at a higher risk for side effects like muscle pains from garlic, for example. A lot of these do have those benefits or potentials to try to help in diabetes, but we do need to be cautious related to that. And then I did see a question there. I'll definitely answer that at the end. Thank you for that. And then potential, kind of going on to the next slide with other benefits for those supplements. Most of the ones that I showed you on this, or excuse me, all the ones that I showed you on the slide have shown to have some sort of benefit in diabetes. It's important to know that they should never replace any of the standards of care that Kaylin has kind of gone through as far as that goes. They could be supplements or add-ons for people who are interested in that type of treatment, but we do need to be cautious with that. So whenever there's a doubt, definitely send them over to one of their pharmacists or to their physician to make sure that those medications are safe. Additionally, a lot of these supplements don't necessarily take overnight. It's not like I take cinnamon and the next day my blood sugars are back to perfect and my A1C is going to be 7. No, these actually take closer to about 12 weeks to work. So, about 3 months to kind of kick in and see some of those benefits. One other one that I just wanted to touch on is a medication called alpha-lipoic acid. And that has shown some benefit in diabetic neuropathy. So I've had some older adults who might be on things like gabapentin or Lyrica, but they're having side effects. Their legs are swelling up, or more notoriously, they're having problems with balance and falling. And so alpha-lipoic acid is an alternative to some of that to try to maybe help a little bit with the nerve pain, along with other options that might be safer, such as duloxetine, brand name for that being Cymbalta. And then we just wanted to touch on some key interactions and some pieces within diabetes medications. So first, with hypoglycemia risk, most of the medications, I think we've all seen all the ads on TV, when combined with sulfonylureas can increase your risk of lowering your blood or causing hypoglycemia, right? And so you can see on the left, we have medications that don't typically cause severe hypoglycemia kind of by themselves. However, on the right, we can see that sulfonylureas, like Kaylin has kind of talked about, as well as obviously insulin, can increase our risk of hypoglycemia. And when we do that with older adults, and that's maybe why we want to lower our or make it so that an A1C less than 8 might be more appropriate. We definitely want to reduce our risk of falling. So as we start to combine agents that increase our risk of hypoglycemia, such as a sulfonylurea with an insulin, that would be a combination we'd want to look out for. Additionally, within the sulfonylurea class, glimepiride and glyburide are not recommended for prolonged use for use in older adults, primarily because they have active metabolites and they're cleared by the kidneys. So we build up those over time with kind of slowed kidney function, and that can increase our chances of having low blood sugars, which increases our chances of having falls. So if we do have to use a sulfonylurea in an older adult, the preferred one is glipizide. And then I think heart protection and heart failure has been a huge thing in the past, again, probably like 10 years. All the medications that are getting approved have to have some sort of cardiovascular outcome. Looking at that, making sure that they don't worsen anything cardio related, and hopefully protect them. And so Kaylin did talk about some of those options that do have the benefit of protecting our heart in the long run. One of the ones that's pretty notorious in heart failure that we want to try to avoid is things like rosiglitazone or pioglitazone. There was some controversy about whether those caused heart failure. That has since been disproved that they don't cause it, but one of their most common side effects is edema. So if people are having swelling in their legs and causing that edema, that's harder on the heart, and that could worsen heart failure or lead to a hospitalization with heart failure. So when we choose those medications, interestingly enough, I just wanted to point out that dapagliflozin was recently approved to reduce the risk of cardiovascular death and hospitalization in people who have heart failure with a reduced ejection fraction. You'll notice that that doesn't even include people with diabetes. So even people without diabetes may benefit from these drugs in heart failure. So if we start seeing people with heart failure, these could be potential add-ons that would show benefit for them. And then lastly, just between the classes of diabetes medications, I like to point this one out. So DPP-4 inhibitors, that's things like Januvia, Tradjenta, Onglyza. They work by inhibiting an enzyme in the body to try to increase the amount of GLP-1, or incretin is what it's called in the body. And that's kind of how they do their mechanism. And then we have options like GLP-1s, which just replace the endogenous molecule. Those are things like Trulicity, Ozempic, and Bydureon. So essentially, if we're using both of these, we're working on the same pathway, whereas most of the other medications work on unique pathways. And so we have a bit of a duplication of therapy. We do find that the GLP-1 agonists tend to do a little bit better at lowering A1C over time. And like Kaylin mentioned, several of them do have the benefit of preventing heart attacks or strokes as well. So moving on to continuous glucose meters. Recently, as recently as this summer, CMS has actually made some pretty key changes to who is eligible to receive a CGM. They're removing the requirements for beneficiaries to be testing at least 4 times a day. And they're also changing the language within there to change from multiple daily injections over to multiple daily administrations. This helps open it up to more people who may be on inhaled insulin, for example. Now, in the future, we may see even more changes with this. Several diabetes advocacy groups are working on trying to expand the eligibility for these CGMs because they have such good control with a lot of people with diabetes. They want to make it for everybody who has chronic kidney disease. They want to make it for everyone who has type 1 diabetes. Basically, essentially, they're just meeting with their doctor on a regular basis. They also want to try to expand it for people with type 2 diabetes. And they just want it to be people who are on insulin and have some sort of documented hypoglycemia. Essentially, this would try to get rid of like the multiple daily administrations requirement that we currently have. And then when it comes to CGMs, I just wanted to give a quick review. There's a couple different ones. There's a couple on the market. These are the most recent ones by the two main companies. Freestyle Libre didn't necessarily start out as a CGM, but now they've been approved as a CGM device. They're indicated for people who are age 4 and older. We change out that sensor every 14 days. And with this one, we utilize the reader that comes with it to swipe and tell us what the blood sugars are. That reader can connect to a phone and you can use it that way, but the sensor doesn't go directly to the phone just yet. That technology has not been FDA approved. As far as drug interactions with this one, we try to limit the amount of vitamin C that people are supplementing with because doses over 500 can cause people to miss some hypoglycemic episodes. As far as the Dexcom, the G6 and the G6 Pro are brand new, are our newest ones that we have. Those are going to be indicated for people age 2 and older. We are going to change out the sensor every 10 days. And with this one, you can either utilize a smartphone or you could utilize the reader that comes with it. And those do pair directly with it. They do have an extra benefit that they can combine with the T-Slim as well as the Omnipod Dash and provide some like boluses of insulin with that as well. And then when we talk about drug interactions, obviously the pharmacist has to hit that. Taking Tylenol up to 1,000 milligrams every 6 hours, which is the normal dosing, will not affect these new products. So it's a good thing to know because in the older ones, we definitely had some issues. So as long as people are taking acetaminophen or Tylenol as prescribed, we shouldn't have too many issues with that. All right, next we'll move over to statin use in diabetes with Kaylin.
All right, so we're going to move on to talking about statins and diabetes. Basically, we're going to review who these should be recommended for and what the benefits are. As we know, just having a diagnosis of diabetes really increases the cardiovascular risk. And so statins are recommended to help to lower that risk and better protect these individuals. There are 2 different guidelines that kind of tell us what we should do in regards to diabetes and statin medicines. One of those is the diabetes guidelines, so the ADA guidelines that we already talked about. And then the other is the ACC-AHA guidelines. So this is more of a heart-based guideline. And basically, in summary, there's 2 different guidelines that talk about this, but they pretty much say the same thing. So what they recommend is that all individuals that have diabetes and are between the age of 40 to 75 should be on a statin. And one really good thing to understand about this is regardless of their cholesterol levels. As we talked about, it's really recommended to lower the cardiovascular risk. So it's there to help to lower the risk of heart attacks and strokes. And this is a very helpful counseling point when talking to individuals. You find a lot of people that stop taking it or aren't taking it because their cholesterol levels are fine. And they forgot the fact that it's doing more than just helping with their cholesterol. So oftentimes when we talk to people about the fact that it's lowering the risk of having a heart attack or a stroke, they're a lot more excited to take it. Obviously, there are some reasons why people may not be on them. Most typically, it's people who can't tolerate the statins, maybe people who are at the end of life or on dialysis. But I'd just like to point out that there are many different statins, and some of them are much less likely to cause side effects like the muscle pains than others. So just because somebody didn't tolerate one statin doesn't mean that they couldn't try a different one and see if that one works better for them. And there's, opportunity for different statins. There's also opportunity to do dosing that isn't every day in order to help to minimize the risk of those side effects. Next, moving into just a few helpful tools that we like to use and they may be beneficial to know about or to potentially use. The first is that Mayo Clinic has some very helpful public online tools that can be used for shared decision making. And this one is specific for diabetes and picking medicines. So I find that this is a really great tool to pull up during meetings with individuals. And the reason being that it can help them to pick a medicine that best fits their lifestyle and best fits what they're comfortable with taking. So the way that it works is this is just a screenshot of the website here, but you can click through each of the different medicines and it helps to tell you how well it might work for your A1C, how you take it, what are the risks of side effects, and that kind of thing. And I find oftentimes that if you allow someone to have some say in what they're going to take, they may be more likely or more motivated to want to take it. This one is similar, but instead it's a shared decision-making tool for statins. And so the way that this tool works is it has you put in some information about the individual to figure out their risk factors. And on the left, it shows what is your current risk of having a heart attack. And then on the right, it shows if you started a statin medicine, how many people is that going to help save from having a heart attack? So sometimes visually seeing this can be helpful for people to understand what these are doing for them. This one I know is too small for you to see, but just showing it as a visual. This is in the ADA guidelines. It's a very helpful little chart that you could print out or save to your computer. It goes through the different drug considerations. So it's a really helpful tool with a summary of the benefits, the risks, and the key points about all of the different drugs and drug classes for diabetes.
All right. And lastly, we just wanted to talk to you a little bit about the work that Kaylin and I do, which is medication therapy management, or MTM, and really how a pharmacist can help the healthcare system and help you help patients, essentially. And so just a little background. I know that our supervisor, Erica, presented a couple of years ago and probably brought a bunch of this, but as we know that medications are a large healthcare cost, and that's where a pharmacist can maybe come in. Looking at over 50% of prescriptions are taken incorrectly or not taken at all. That's a huge part of it. The drug-related morbidity and mortality costing about $200 billion per year. That's a huge number. And then lastly, at the health plans, we absolutely know that STAR and HEDIS measures are very much influenced by medication use. And so utilizing a pharmacist may be a helpful way to help with adherence and help with reducing the overall healthcare cost, improving a medication experience for a patient, and making sure that we're doing the best we can for our patients. So what really is MTM? Well, there's a whole bunch of different options out there for what people kind of call it. But in general, it's basically an opportunity for, or it's a kind of a group of services that a pharmacist can provide for a patient to try to help improve therapeutic outcomes for patients. Within this class of MTM, there is a specific type of visit that Kaylin and I do frequently. These are called CMMs, Comprehensive Medication Management Visits, or another name for them is CMR, Comprehensive Medication Review, which is CMR is the one that's Medicare uses in a lot of theirs. And so these reviews are all encompassing. So we've probably heard of a medication reconciliation. That's where we just take all the medications that the patient's taking, we reconcile the group and make sure that we have everything on the list and that they're taking those medications. A CMR, or a comprehensive medication review, is much more encompassing. We look at 4 main facets that we'll see on the next slide, and that is indication, effectiveness, safety, and convenience. So I like to look at all of those for every single medication that a patient is taking. What do I mean by indication? Well, we want to make sure that the drug is indicated for the disease that they're using it for, or if they're taking it and they're no longer need to take it, maybe they aren't indicated to have that one anymore, and we could take a medication off the list. We also try to look for that therapeutic duplication, things like I talked about with that DPP-4 and the GLP-1 earlier. Also, effectiveness. Is our dosing right? maybe we're not on a high enough dose to get the benefit. Medications are not effective if we're not taking them. So absolutely hitting on adherence is important for that. And then checking any lab values to make sure that those are, we're hitting the goals that we want for a patient. As far as safety goes, perhaps the dose is too high. Perhaps we talk about drug-drug interactions, and a lot of time we think about that as a pharmacist. Well, Kayla and I also looked at like to look at drug disease interactions. So with NSAIDs, for example, if in a person with congestive heart failure, that might not be a very good option because we could increase their chances of cardiac events or worsen their blood pressure in the process. We look at adverse events. So making sure that the common ones are not being caused upon the patient and making sure those medications are working safely for the patient. And then lastly, we look at convenience. Things like, do we have access to getting our medications? What's the cost of those medications? And trying to take things and, if we can, simplify a drug regimen. I know, for example, my mother was taking a blood pressure pill and she just had surgery, and she doesn't like to drink a lot of water, but it was a diuretic. And she goes, gosh, I really don't like having to get up, and I feel really dry all the time. And I'm sitting there and I go, well, Mom, there's a bunch of different blood pressure medicines out there. Perhaps you could try something else just so that it's not inconveniencing you so much, and the medications can fit into your life and not the other way around. And she didn't necessarily think about that piece. So something Kayla and I like to hit. MTM can be practiced in a whole bunch of different settings. And the three that I've had experience with, and the primary ones that we do see, are things like community pharmacy, clinic pharmacy, or within a clinic and a pharmacist in a clinic, and then at a health plan. A lot of companies such as UK, are taking MTM and bring it within house to kind of control it a little bit more. I know we also allow for several clinics to do this as well for us. There's kind of pros and cons with each one. And I can let you kind of go through that list. But I would say within a clinic, it can oftentimes be more well received for a patient receiving an MTM. And this could be a place where maybe you could help the pharmacist in this case. And if you notice a person is struggling with some of their medications, to steer them towards their clinic pharmacist, or steer them to a community pharmacy, or steer them towards their health plan pharmacist to help with these problems. That's absolutely what we're here for, and we're more than excited to help with that. Additionally, I think that we, especially from those who are taking it with the health plan, have a unique opportunity to talk about drug costs with members and their formulary to make sure that they better understand it. Within all these settings, I really think the key is for us to help empower patients to understand their medications better and navigate within the healthcare system. So in summary, related to MTM, medication or pharmacists can provide that unique lens for patients in the healthcare system, as well as providers too, providing information that way. MTM is by no means intended to compete with providers, to overstep on any of that, but instead it's more of like an added benefit in the healthcare system to help people understand their medications. Studies have shown over and over again that a pharmacist can help save the healthcare system money and improve adherence. And then lastly, when we do provide these recommendations, sometimes they do come into the care coordinators within clinics or systems. And we are really trying to give you the most updated information from things that we learned, and then use that partnered with all the information that you have to help better serve those patients. So we just wanted to show a couple of quotes from some members just to kind of give you an idea of what we're seeing and what we mean by the last slide. And so one member we had just said, I don't always understand my medications. This is so helpful. And so for us, just taking time to explain from a pharmacist view how these medications work, or that taking your statin is going to reduce your risk of having a heart attack or stroke, is one of the ways that we really come into play. Someone saying, I have great faith in my healthcare team. I was hesitant to do the review, but they found it beneficial and no downsides at all. So we never really push anything on people or anything like that. But instead are here to be a support within that healthcare system to help people. Someone saying that they've been researching and not finding the answers they need, but meeting up with a pharmacist made things easier to understand and understand how those therapies fit in there. So that's a big part of what we like to try to do, which also improves adherence for people. And then lastly, someone saying that what we really did was reassure that they're on the right track. And that can be something that can be very beneficial too. Hey, my diabetes A1C less than 7, I go see my doctor. I know what my goals are. That's phenomenal. To hear that from multiple angles is only going to charge somebody up and get them more excited to be adherent with their medications and move forward with that. And with that, we'll go ahead and take some time for any discussion or questions that anyone has.
There was the one question in the chat about if supplements are safe to take long-term.
Yeah, perfect. That was definitely one that I saw. So as far as supplements go, we usually don't have a lot of studies on them, right? They're not FDA approved. Their labeling is definitely different from that. We don't even know if necessarily what they have in there is exactly what they put on the bottle because they're regulated different. So when it comes to those supplements, all the ones that I showed, there is varying studies with those that usually show safety within the doses that I showed for about 3 months up to maybe a couple years. So there isn't a ton of things for the long-term safety of those. However, many of those are in various things in your diet, which you may eat anyways. So as far as long-term safety goes, I don't think that we can ever be 100% sure on anything related to that. But we do have some studies showing that in the short term, they have been safe and well tolerated by most people. That's a great question, though. Thank you.
Another question here is, what's the best way to make a referral for this? And is an order from a provider needed?
Yeah, I would say, that question's a little bit tricky to answer just because depending on where you are, that's definitely going to be different at different places. So it really just depends. I mean, if you're working within a health system or within a health plan, it's good to know specifically what the requirements are at your place, but there isn't really a one type answer that fits everywhere just because it's very different depending on where you're at. But if you're talking to someone and you're not really sure, sometimes what you can do is just kind of explain what the service is and what they could maybe ask about. I know a lot of times from the health plan setting, we'll have people that we may want to refer to continue doing more MTM within their clinic. And so, I don't know for sure that it exists at every single clinic, but where I do know, I can refer them directly. And if I don't know, I can just explain the service to them and have them help or know what they should ask for when they want to call their doctor's office and ask about it.
I think that's a great point, Kaylin. And I'll only add to that if someone's ever concerned about what kind of coverage that they have on those things, always just check in with the insurance company, asking specifically for the service, just say MTM or comprehensive medication review. And most companies should understand what that is and who's eligible.
We have another question here. This one is, I wear a CGM and my CGM monitor is 20 points lower than my glucometer. What do I go by?
Kaylin, do you want to take that one or you want me to?
You got it.
All right. So the CGMs and the glucometers measure slightly different things. So I believe that the CGM is actually going to be a little bit ahead of where your finger pricks might be. So that could be contributing to it. I would say that neither of them is necessarily a perfect system. So I'd probably try to average in between as far as that goes, where kind of your blood sugars are running. I'd be most concerned if you're having issues with hypoglycemia. And I think that would be probably the easiest time to tell which one is going to be more accurate for you. So if you start to feel the shakiness, the sweating, the hunger, all those things that come along with hypoglycemia, and you are dropping low, check what your CGM is, check what your glucometer is, And I think between those two, you'll kind of find out which one's maybe a little bit more accurate between the two of them.
Any other questions? Question is, are the health plans covering insulin pumps?
Yeah, I would say, again, on this one, a little bit hard to say for every single health plan, but I would say most health plans have at least some amount of coverage on insulin pumps. Some cover them fully, some cover a certain percentage and require the patient to pay a certain percentage. It really just depends, but oftentimes, at least for sure for type 1 diabetes, the insulin pumps tend to have some coverage.
Any other questions for Kaylin and Grant? Well, thank you very, very much for, oops, one more question. Any comments on COVID and diabetes?
I guess my biggest comment would be we've definitely noticed this a lot. We've seen a lot of blood sugars and A1Cs that have trended up quite a bit because of COVID. So that is, something that has been coming up very commonly for us. And we've had people who, they know why it happened. They know, hey, I wasn't able to get out for my walks or do this activity that I usually do. And so just reminding them of what they were doing before to help keep those blood sugars down has been very helpful and gets people excited to get back doing things when they're able to.
Absolutely. And I think, when it comes to, COVID in general and maybe vaccine hesitancy, obviously anyone with a diagnosis of diabetes is going to be a little bit higher risk for infection or complications. So definitely hitting on the importance of that vaccine is going to be huge.
I see another question. What about someone who may not be on any medication currently? They stopped it due to side effects and they've been off it for some time. Can they have MTM or a CMR to discuss other options that may not have been tried? I would say absolutely. These are, some really good candidates. It doesn't matter whether, whether they're on medicines or not. We're talking about the topic of health conditions and medicines in general. So pharmacists have time to really talk through some of those concerns and why they've stopped things, and maybe talk about some things that would better fit into their life, as Grant was talking about. So those are definitely good people to think about for MTM and for working with a pharmacist.
Well, if there's no more questions, we'll give everybody back 5 minutes. Thank you so much, Grant and Kaylin, for your great presentation. You gave a lot of great wealth of information. We really appreciate your time. When you sign out of this webinar, you'll see the evaluation and certificate of participation, and that certificate will generate after you complete the evaluation. Also, this was recorded today and it will be out on the Stratus Health website in a few days here. So for those that may have missed today's presentation, you're able to go back and listen to it at your convenience. Again, a big thank you to both of you. We really appreciate this, and everyone have a wonderful day. Thank you.
Thank you. We really appreciate everybody coming.